Boa tarde, eu me chamo Ayrton Roberto Pastore, sou um dos moderadores dessa sessão, juntamente com o professor Luiz Ronan, e tenho a satisfação de estar nessa mesa, aqui no SPR TV, para apresentar um tema bastante importante, que são as massas uterinas, a correlação radiológica e patológica. Comigo, quem vai fazer agora a apresentação desse tema é o professor Jamie Marco, dos Estados Unidos. Ele é Associate Physician in Chief Imaging do American College of Radiology Institute for Radiological Pathology, e também é professor associado de radiologia das Universidade das Uniformed Service University of the Health Sciences em Bethesda, e também Staff Radiologist Body Imaging Section Walter Reed National Military Medical Center de Bethesda. O professor Luiz Ronan, ele também pessoa bastante conhecida aqui no nosso meio, sempre coordenando, colaborando. Luiz Ronan Marques Pereira de Souza, ele é de Minas Gerais, médico especialista em radiologia abdominal, professor associado, doutor da Universidade Federal do Triângulo Mineiro, e é gestor médico e radiologista do CEIB em Medicina Diagnóstica. Então, nós vamos dar início a essa apresentação, passando a palavra para o professor Jamie Marco.
Okay,
please.
Hello, everybody. My name is Jamie Marco, and I'm very happy to be with you today to discuss uterine masses with radiologic pathologic correlations. This is my disclosure. I do some research work which is unrelated to the topic that I'll be discussing here today. So when I think about the uterus, I like to divide it into two major compartments. We have the endometrium and the myometrium. The endometrium is our epithelial lining of the uterus, and it's commonly affected by conditions such as hyperplasia, carcinoma, and endometrial polyps. The myometrium, on the other hand, is affected by mesenchymal processes such as smooth muscle tumors, including the leiomyoma, its many variants, and leiomyosarcoma. We can also see adenomyosis as a mimic. But in this presentation, we are going to focus on our smooth muscle tumors involving the uterine myometrium. So here is the spectrum of smooth muscle tumors that you may encounter within the myometrium. They range from a benign leiomyoma, which may be classic in appearance or show different types of degeneration. Then we have a long list of leiomyoma variants that you may encounter. And then at the malignant end of the spectrum, you have leiomyosarcoma. Now, between the leiomyoma and the leiomyosarcoma, there's uncommonly diagnosed tumor of uncertain malignant potential called a stump tumor. So let's start at the benign end of the spectrum with leiomyoma, otherwise known as fibroids. Now, these are our benign smooth muscle neoplasms. They are extremely common. It's estimated that they occur in about 25% of premenopausal women. Know that they may be symptomatic. And some potential symptoms include bleeding symptoms, bulk, things like pressure and voiding issues, pain, which may relate to mass effect on other structures in the pelvis, or infarction, and then reproductive dysfunction, especially if there is a large number of fibroids or they are submucosal in location. But please be aware that many cases are actually asymptomatic. So what are the pathologic features we expect to see? Well, this is going to be a neoplastic proliferation of cells, and those cells will be spindled in morphology, and they will often have oval or elongated nuclei. Now, these spindle cells will form bundles that resemble the normal myometrium. And because they are benign tumors, they're going to have few, if any, mitotic figures, no nuclear atypia, and no tumor necrosis. At gross pathology, what we expect to see is a mass which is myometrial based. They are typically discrete, round, and circumscribed. Those circumscribed margins will become important when we look at the imaging findings. They're often homogeneous, and they will have a gross whorled appearance, reflecting that organization of the spindle cells into those muscular bundles. Leiomyomas, it's important to describe their location. General locations include pedunculated or intracavitary. You can nicely see here this intracavitary lesion on a stalk pedunculated hanging down towards the cervix. You can also describe cases as submucosal, where they contact the endometrium. You can have intramural fibroids, or you could have subserosal fibroids. Now, usually we try to be as specific as we can be as we describe the location of leiomyoma. So actually there's a FIGO subclassification system which is available to us that goes from 0 to 7. Providing the precise location can be helpful to our gynecology colleagues. One, the location will correspond to symptoms. For example, it's more likely to have reproductive dysfunction or bleeding with a submucosal fibroid, and it's more likely to have bulk symptoms with a large subserosal fibroid. Additionally, if there is contemplation of doing a hysteroscopic resection of a submucosal fibroid, knowing how deep that fibroid extends into the myometrium can be helpful to the gynecologist to try to prevent uterine rupture. Okay, what do we expect leiomyomas or fibroids to look like at ultrasound? Well, we'll see one or more masses. They're often hypoechoic or potentially heterogeneous in appearance. They will result in sound attenuation or shadowing, and sometimes the sound attenuation can be so strong it'll be difficult to see the mass itself. And if they're subserosal in location, you may see deformation or distortion of the uterine contour. So here are some ultrasound examples of leiomyomas. We see here a calcified fibroid, which is intramural in location. This would be a FIGO class 4. We have a submucosal fibroid that pushes out, deforms the uterine contour, but by less than 50%. That would be a FIGO class 5. And here we have a subserosal fibroid which has greater than 50% extending beyond the expected contour of the uterus, so that would be a FIGO 6. Now what about at MRI? Well, the MRI can allow us to look at both macroscopic and microscopic features of your typical fibroid. So macroscopically, we expect to see one or more myometrial masses. Again, they should be discrete, rounded, and circumscribed. The microscopic features will lead to the signal intensity, so we expect to see homogeneously T2 hypointense lesions that show relatively homogeneous enhancement. Okay, so here is a classic example at MRI. We see many myometrial masses. They are uniformly T2 dark. They are very sharply marginated, and they show internal enhancement. These should not be confusing to us. These are typical examples of leiomyomas. Here's another example where we have a large dominant fibroid. It is T2 dark. It has circumscribed margins. It embutts the endometrium. This is a classic leiomyoma. Now, sometimes leiomyomas can undergo degeneration, and there's a variety of degeneration types. Okay, so you can have hyalinization, which ultimately can lead to calcification. You can have myxoid or cystic degeneration, which will result in increased T2 signal intensity. You can have hemorrhagic degeneration, which will lead to increased T1 signal intensity. And I put a question mark here by sarcomatous degeneration. The thought is that the large majority of tumors that turn out to be leiomyosarcomas actually develop de novo rather than as sarcomatous degeneration of a formerly benign leiomyoma. So here's an imaging example where we see early degeneration. It's likely hyalinization. Notice that we have well-defined, predominantly T2 dark masses within the uterus that show enhancement. Notice that there are small areas of hypoenhancement and high T2 signal intensity. That's that early sign of degeneration. This can result in some degree of heterogeneous enhancement. The fact that most of the mass is T2 dark and sharply marginated are reassuring features. Okay, here's an example of a more complex case. Here we have a large subserosal fibroid arising from uterine fundus. Notice that this mass has high T2 signal intensity. That high T2 signal intensity represents myxoid degeneration. Okay, here's another example where we have a combination of myxoid degeneration as well as hemorrhagic degeneration. Notice that the myxoid degeneration in our first image results in high T2 signal intensity. Our hemorrhagic degeneration results in areas of increased T1 signal intensity. Our gross pathology image nicely shows the well-defined margins of a typical leiomyoma and is red in color related to that hemorrhagic degeneration. Okay, here's an example of severe hemorrhagic degeneration. Nearly the whole mass is T1 hyperintense. Notice there is no internal enhancement on our post-contrast images. This would be a non-viable fibroid due to severe degeneration and one we would not want to treat with embolization. So now that we know what our standard leiomyoma looks like, what about the variants? Okay, here's that long list of variants. And I want you to know that the ones listed here in white are pathologic diagnoses. There are not imaging findings for them. The ones in green result in a high T2 signal intensity within the fibroid, which can make us start to be concerned that it's not truly a fibroid. The ones listed in yellow show invasive behavior, and they become increasingly confusing for us as radiologists. And the one listed in orange is the easiest one for us because it contains macroscopic fat, which we are very good at detecting. So let's start off with the easy one. This is a lipoleiomyoma. This is when you have a benign smooth muscle tumor that has intermixed areas of mature fat or adipocytes. The imaging finding we're going to see is the presence of macroscopic fat within a uterine mass. Probably our biggest challenge is to make sure we don't make the mistake of calling this a liposarcoma. Okay, so here's an example at ultrasound. Notice we have a uterine mass. It's very hyperechoic. That's because of the internal macroscopic fat. Okay, here's another example. This is a large subserosal fibroid. It has a nice claw sign with the uterus. Notice that there's a large area of macroscopic fat within this mass, confirming that this is a lipoleiomyoma. Okay, this case was resected anyway due to patient symptoms, and you can see that this mass was very large. It is predominantly solid. There is a small area of cystic degeneration, but importantly, there's this yellow material here. That yellow material is that mature adipose tissue that allowed us to make the diagnosis. You can see at histology, it's a mixture of mature fat as well as the smooth muscle cells. Okay, here's another example. This one has made the transition to nearly complete fat attenuation at CT. You notice the bright yellow color of this mass reflecting the large amount of fat at histology. Okay, here's another example. We have a subserosal uterine mass. Notice that it is mostly soft tissue attenuation, but there are some small areas of high T1 signal intensity which decrease on fat suppression. That corresponds to the yellow material that we see here at gross pathology, okay, confirming a lipoleiomyoma. Okay, our next variant is our myxoid leiomyoma. These are hypocellular benign smooth muscle tumors with cells that are widely separated by a myxoid stroma. These tumors will maintain a normal, well-defined border, but they will become low attenuation at CT and show high T2 signal intensity. Okay, so here's an example. We have a large mass replacing the uterus. It is somewhat heterogeneous, but overall low in CT attenuation. This case went on to MRI for further evaluation, and I want you to notice that the mass largely enhances, except for the small regions of non-enhancement. Those areas of non-enhancement may be degeneration or necrosis. If we look at the solid enhancing components, notice that it's relatively T2 bright, which is not in line with what we would expect for a classic leiomyoma. Because of this, the mass went on to surgical resection, and here is in the operating room, you can see the large size of this uterine mass. And then as we look under the microscope, you can see that it is a spindled smooth muscle tumor without malignant features. But all of this pink material between the cells, that's all that myxoid stroma, which led to the high T2 signal intensity. These areas here are areas that did not show enhancement because those are areas of cystic degeneration. Okay, another subtype or variant of leiomyoma is the dissecting cotyledonoid leiomyoma. These are characterized by irregular dissection of bland smooth muscle cells within or beyond the myometrium. These are often hydropic at pathology and therefore are T2 bright. So here's an imaging example. We notice that there is the uterus located centrally within the pelvis, but there is this strange mass extending in the perauterine space. It's relatively low in density, likely reflecting that hydropic change. When this mass was resected, it turned out to be one of these dissecting cotyledonoid leiomyomas. When a pathologist takes a look at this specimen, they think it looks like it's organized into placental lobes, and that's where the name derives. Okay, our next variant of leiomyoma is our intravenous leiomyomatosis. This is when we have benign smooth muscle within the vascular spaces outside the confines of a leiomyoma. Oftentimes, the tumor will appear like worm-like growth within the vascular spaces. The tumor may be free-floating within the vessel lumen or adhered to the vessel wall, and they're usually vascular, meaning they enhance, and hydropic, meaning they are high in T2 signal intensity. Okay, so here's an example of intravenous leiomyomatosis. Notice here this large uterine mass, relatively T2 bright, heterogeneous in appearance, and there's extension of tumor up the gonadal vein into the IVC to the level of the right atrium. Notice that it is T2 bright because it's hydropic. Here are post-contrast images, and you can see how vascular this uterine mass is, as well as the enhancing tumor thrombus within the IVC. This case went on to surgical management, and the gross specimen is kind of hard to orient yourself with, but this is all soft tissue mass. And then here is the elongated tumor that had found its way to grow up the IVC. When it was looked at under the microscope, you can see here again, these are spindle cells. They do not have malignant features, and the portion of the mass within the IVC was very hydropic with all these white spaces. Okay, an extension of this idea of intravenous leiomyomatosis is benign metastasizing leiomyoma. This is when you have a tumor that resembles a typical leiomyoma at histology, but is found in the lungs of a woman with a history of typical leiomyomas. Okay, so here is a case example of benign metastasizing leiomyoma. Notice the uterus is absent in this patient who had a history of hysterectomy. She presented with pain, and when she was scanned, they noticed that there was enhancing tissue along the course of the gonadal vein, as well as bilateral masses in the lower lobes. These masses were concerning for potential malignancy, so they went on and had a right lower lobe wedge resection or right lower lobectomy, and you can see here this white, well-circumscribed mass with a somewhat whorled appearance that turned out to be a benign smooth muscle tumor at pathology. So this was a benign version of leiomyoma, just metastatic to the lung. Okay, we've seen leiomyomas go many different places, and the next place they can go is to the peritoneal cavity. This can be called diffuse leiomyomatosis or leiomyomatosis peritonealis disseminata. This is when you have spread of benign leiomyoma, not malignant leiomyosarcoma, out to the peritoneum or the omentum. This can be just a few masses or can be hundreds. And the key is that there's no atypia or necrosis or mitotic activity at pathology. Okay, so here's a case example demonstrating diffuse leiomyomatosis. Notice there is this subserosal fibroid arising from the anterior uterus. There's also this right-sided pericolonic mass, as well as a serosal liver implant. These are obviously concerning findings. The patient was managed with surgery, and here are the gross specimens. But importantly, all the sites of disease looked benign without necrosis or atypia or abnormal mitotic activity. Here's another case example. We see this nice uterine mass here, somewhat heterogeneous in enhancement, but we see many calcified and non-calcified soft tissue masses distributed throughout the pelvis, even extending up into the abdomen. If one sees this, they would obviously be concerned that this is carcinomatosis, potentially serous-related disease given the calcifications. So this patient went on to surgery, and you can see here, this is a gross specimen that has not been sectioned, but you can appreciate that there's multiple leiomyomas sitting on the serosal surface of the uterus. Here is the resected omentum. You can see the large number of soft tissue nodules within the omentum, as well as in the small bowel mesentery. Okay, so this is a nice example. When they looked at this example at pathology, you can see that there were many masses with a somewhat whorled appearance in areas of dystrophic calcification. And importantly, at high power histology, these were bland cells, again, without necrosis, without abnormal mitotic activity, without atypia. So a benign pattern of leiomyoma. Now, MRI can be helpful in these cases because fibroids we know are going to be well defined in T2 dark, while carcinomatosis should not have that characteristic T2 dark appearance. So if you're fortunate enough to have an MRI, you may be able to detect the uterine mass as well as see the peritoneal nodules demonstrating low T2 signal intensity. Okay, our last topic is going to be the malignant end of the spectrum, which is leiomyosarcoma. These are uncommon malignant neoplasms that arise from the smooth muscle or potentially endometrial stromal precursors. They are bad tumors with a high morbidity and mortality. They frequently recur after surgery. They often metastasize, and they have a relatively poor 5-year survival. What separates a leiomyosarcoma from a benign leiomyoma is the presence of nuclear atypia, abnormal mitotic activity, and the presence of tumor necrosis. Now, what do these look like at gross pathology? Well, they're often bulky, fleshy masses that are invasive of the uterine wall. Remember, we have said that leiomyoma have sharp margins. Leiomyosarcomas, given their invasion, will have ill-defined margins. Occasionally, they will have a more polypoid appearance with extension into the endometrial cavity, which can, in that case, mimic an endometrial cancer. So our challenge is really how to distinguish a benign leiomyoma from a leiomyosarcoma. I showed you a number of atypical patterns of leiomyoma that make things even more complicated. But here is a list of some of the features we can use to try to raise the possibility of leiomyosarcoma. So the first would be extrauterine disease. So if we see evidence of peritoneal metastases that are not T2 dark or malignant lymph nodes, that's going to be a suspicious finding for leiomyosarcoma. If we see a tumor that instead of being circumscribed has invasive margins, starts to show locally invasive behavior, maybe invasion of a pelvic organ, that is going to raise our suspicion. If we see rapid growth, especially in a postmenopausal woman, if we see irregular, ill-defined margins, again, that doesn't seem to fit with what we expect for a leiomyoma. If we see heterogeneity, that can push us towards leiomyosarcoma, but there is overlap with degeneration. And then finally, there is an MR algorithm that we can employ that I will show you in a moment. Okay, so let's just look at a few examples of leiomyosarcomas. Our first example shows a large uterine mass, which is, so it shows central necrosis. This could potentially be generation, but in this case, we saw peritoneal disease involving the right psoas muscle, confirming a malignant process. Okay, here's another example where we have a large mass involving the lower uterine myometrium. Notice it is T2 hyperintense, which is atypical for a leiomyoma. It shows areas of necrosis, and then there's frank invasion of the posterior bladder wall. Okay, here's another example. These are scans in the same woman separated by only 2 months. Notice the marked increase in size of this mass, so this is rapid growth. Notice the heterogeneous appearance and the ill-defined margins, highly concerning for leiomyosarcoma. Okay, here is a mass that is large in size. It's T2 hyperintense, which again is atypical for a leiomyoma. It shows heterogeneity with areas of necrosis. We also see ill-defined margins inferiorly, which are concerning features. Okay, and then the final thing is to be aware of a recently discussed algorithm that has been developed and widely published. This is how do you handle a typical uterine mass that is not typical by imaging. Okay, so typical would be T2 dark and well-defined. Atypical would be the opposite of that. So in this case, we have an atypical mass because it's heterogeneous. How do we handle these? Well, we look for metastatic spread to either the lymph nodes or the peritoneum. If that is not present, then we assess the solid component of the mass and decide is it dark or bright. If it's bright, that remains concerning. And then we look at that solid component, which is T2 bright, and we assess for restricted diffusion. If it is brighter than the adjacent endometrium, that is concerning. If it's dark on the ADC map, that is even more concerning. And then if you have the ability to quantify your ADC measurement and you get a value less than 0.9, that is the most concerning finding for a potential leiomyosarcoma. So in this case, it read the book. It was heterogeneous, T2 bright, had invasive margins, was bright on high B-value imaging, and had restricted diffusion with a value of 0.65. So this mass went on to surgical resection and turned out to be a leiomyosarcoma. So in summary, there's a wide spectrum of uterine smooth muscle tumors. These include our leiomyoma, our many variants, and the leiomyosarcoma. Remember, low T2 signal intensity and well-defined margins are characteristic of benign leiomyomas. You can use this MR algorithm that incorporates extrauterine spread, high T2 signal intensity, and restricted diffusion to help you suggest that a myometrial mass is suspicious for malignancy. So thank you very much for your attention. I hope this helped your understanding of myometrial masses.
Hi, my name is Ronan. I'm very grateful to be here. An invitation from Dr. Patrícia, Dr. Ayrton, to see it, ask some questions for Professor Jamie, who have this presentation, an excellent presentation with a few cases from AFIP. I have seen different cases from leiomyoma variants, and leiomyosarcoma. So, Professor Jamie, in your experience, the report of all MRIs you do in your institution, you have a standard protocol of reporting.
Yes.
You always use the FIGO classification. What the most important for a resident who's watching us, that don't miss in a typical case of leiomyoma in report.
Sure. I think for a leiomyoma, the most important thing is to say its location, because it can, one, predict symptoms, but two, if the gynecologic surgeon is considering resecting it, especially by hysteroscopy, you would want to make sure that they know how deep the mass extends into the myometrium, so they don't get too deep and lead to uterine perforation.
So you make the FIGO classification,
Yes.
you make the extension in the myometrium,
Yes.
also the distance from the endometrium, the uterine cavity, so
Yes.
the serosa also, and you make the vascular pattern. You also report it's enhanced too much, enhanced too low, or no?
Not necessarily on ultrasound. I think there's quite a variety in how vascular leiomyomas can be at ultrasound.
Okay. So talking about ultrasound, do you think there's a limit where ultrasound can go in myometrium mass, or there are new possibilities we can use?
I think there's definitely a limit on how valuable ultrasound is in evaluating fibroids. I think the reason it works most of the time is because of how common leiomyomas are and how uncommon leiomyosarcomas are. So I think as long as the mass appears relatively well defined and pretty typical, most of the time you'll turn out to be correct when you call it a leiomyoma. If it becomes large, it becomes heterogeneous, the margins look invasive, which can be somewhat difficult to tell at times with ultrasound, that would prompt further evaluation for me with MRI. And then I think MRI is really the key, because as I tried to show with that algorithm, we can nicely see the margins. We can nicely see the T2 signal intensity, which tells us whether we have to worry or not. If we decide that it is T2 bright and it's something we need to worry about, we also have the functional information from diffusion-weighted imaging, which can now even be quantified to help us feel more confident that a mass is not just a typical leiomyoma.
Yes. The algorithm the professor shows is a new publication. There's too much talk about that in RSNA and in European Congress. There's a AI-driven protocol just to differentiate leiomyomas, classic leiomyomas, degenerating leiomyomas from sarcomas, because there's a lot of talk about that in the media in the United States, because some cases from leiomyomas treated with mosylation, I think the name of the technique in English.
Yes.
And when you do, the radiologist don't recognize there's a potential risk leiomyosarcoma, and the gynecologists don't give attention to that. They can make the mosylation and can disseminate a leiomyosarcoma in the peritoneal cavity. Isn't it? Or there's more thing you can add?
No, that is definitely true. Before, morcellation was done without a bag.
Yes,
So
without
there
the
was the
bag.
ability to spread tumor distally. Now, if morcellation is going to be done, it's contained within a bag to try to prevent that spread. And I think using MRI ahead of time will allow us to suggest that know it's a T2 dark homogeneous mass, it's comfortable that you should be able to morcellate it in a bag if you need to, versus it's high T2 signal intensity and it restricts diffusion, and you have to be as careful as you can be with this case.
Okay.
I think the algorithm is really nice because after the concerns of morcellation came out, I noticed many radiologists would just dictate likely a leiomyoma, but can't exclude a leiomyosarcoma, which is a little too vague and not really helpful to the clinician. So having at least an algorithm that we could use to guide our process and our reporting, I think will make a big difference as we interpret these challenging cases.
So the point I'm viewing, we have ultrasound. That's excellent image method for all the myomas. We have a lot of cases. So if the ultrasound can see some image findings, can maybe some differentiation about echogenicity, for size, for limits, you need to go to MRI and do the algorithm protocol. And the radiologist that's reporting that must follow the algorithm and try to see with the clinical history, a woman in a median age, this history of growing, so add to algorithm, and after that, showing that that's a possible leiomyosarcoma, or no, that's a classic fat degeneration, cyst degeneration. Is that, I understand right?
Yes, I think that's correct, yes.
Okay, so that's very important. So everybody is watching to know the algorithm, know the limitations you can do. In your reports, you say leiomyosarcoma, or you say the possibility, there's like a PIRADS likely score?
Yeah. So not a specific score, and I don't say definitely leiomyosarcoma, but I would say it's a myometrial mass, not typical of a leiomyoma, raises the possibility of a uterine sarcoma, such as a leiomyosarcoma.
Okay. And in your experience, talking about the classic degeneration from the myoma, leiomyoma, in your experience, what most cases you see? The cystic, the red, the fat? What are more common in your practice?
Cystic for sure.
Cystic.
Now that will cause high T2 signal intensity, which we've talked about being a worrisome feature, but it's important to realize that the margins will remain sharp, and that when we're evaluating the T2 signal intensity in MRI, it's not of a cystic component, so it's of an enhancing solid component. Yes. So just because there's some bright cystic component from degeneration in the mass, that shouldn't make us call it suspicious for a sarcoma.
Yes. The professor is reinforcing that sometimes it's very good exercise for residents to see a cystic degeneration of myoma and a leiomyosarcoma, because when you see only the contrast phase, you see, oh, that must be a leiomyosarcoma, but you have to follow the algorithm to see the high T2 signal, compare with the endometrium, compare the diffusion protocol, and all that together, you can make a reasonable choice of saying that's likely to be a leiomyosarcoma or not. And you see some case with tomography. There any space for tomography in leiomyoma history?
For CT tomography, for CAT scan?
Yes.
I don't think in making that distinction, other than if you saw either peritoneal disease, lymph nodes, or frank organ invasion, because really it doesn't give us the same information as T2 signal or diffusion. So really to look for metastatic spread, I think, is the role.
Okay. A few minutes, we're gonna give you another presentation on tomorrow board about ovarian cancer. So, all right, you feel that maybe in the future we're gonna make a classification for more than the FIGO classification made by radiologists, because the FIGO classification is not made by radiology, for the possibility of a myoma, like a myoma reds 1 or 5, or you see that's enough. We stay with the algorithm.
I'm happy with the algorithm, but you could see how that could occur. You know, that you get a rating scale, and if it is below 0.9 on your ADC, and it's dark on ADC, and it's bright on high B value, and it's T2 bright, that would be can't be LIRADS, whatever, MyRads
MyRads
5.
Let's make this the work first.
Yes.
Because sometimes complicate our work, but I know the goal they were looking for it's have a uniform reports in all the world, the same language. That's the most important thing you have to follow. Okay, so that's all my questions I have to this topic. I like, in the name of the SPR, I like to thank you for your presentation, for all the time you have here. Have all wonderful time in Brazil, and devolvo para o senhor, Dr. Ayrton.
Nós queremos agradecer ao professor Jamie a excelente apresentação, o debate do Dr. Renan, com a sua expertise também dentro desse campo dos leiomiomas, e sempre vai ficar ainda pontos a serem melhor pesquisados, com novos avanços tecnológicos, para fazer uma diferenciação mais segura entre as alterações malignas e alterações benignas. Quero agradecer aqui ao professor, ao professor Ronan.
Posso fazer uma pergunta para o senhor?
Pode.
A gente tem alguns minutos ainda. I'm going to ask a question for him in português. Porque o senhor é o livro mais famoso de ultrassom e obstetrícia e ginecologia da América Latina. Na experiência do senhor, ainda temos território para ultrassom para miomas?
Sim. Olha, com relação aos miomas, é a patologia do dia a dia. Nós, hoje, temos, sim, muito boa experiência em relação a fazer esse diagnóstico. Existem situações mais difíceis, né? Às vezes, adenomioma, mioma, que é a forma nodulada da adenomiose, isso impacta muito no tratamento, porque uma cirurgia do adenoma é muito diferente de fazer uma miomectomia.
Perfeito.
Ali, então, é muito importante você ter segurança. Para isso, nós temos que utilizar ferramentas no campo da ultrassonografia. Quais são? Utilizar o Doppler, o mioma tem vários círculos periféricos, enquanto que no adenomioma os vasos são translesionais. Com relação ao leiomiosarcoma, a incidência é muito pequena, 0,1 a 0,2%, e é por isso mesmo que o pessoal não toma o devido cuidado. Mas, no caso de uma miomatose, num útero mais volumoso, são achados incidentais de anato patológico, você ter depois o diagnóstico de leiomiosarcoma. Quais são, do ponto de vista ultrassonográfico, essas características mais importantes? Nódulos volumosos, normalmente acima de 9 centímetros. Nós temos os bordes irregulares, isso aqui foi bem colocado pelo professor Jamie. Nós temos, normalmente, o Doppler, uma vascularização moderada acentuada em praticamente 70% dos casos. Um outro achado muito importante, do ponto de vista ultrassonográfico, é a área cística, porque esses nódulos são muito grandes, crescimento muito rápido, leva a áreas císticas, mas 40% dos leiomiosarcomas têm as paredes irregulares, né? Isso difere normalmente de uma degeneração cística benigna comum que pode ocorrer nesses nódulos maiores. Além disso, do ponto de vista textural, os leiomiosarcomas têm uma sensação mesmo de uma massa sólida, que também difere. Então, na ultrassonografia, se você tiver uma boa experiência, tiver muita atenção, utilizando as ferramentas, nós podemos suspeitar, mas é claro, esses casos devem ser sempre correlacionados, complementando o estudo com a ressonância magnética, que através de técnicas também, aí eu não sou tão expert, mas difusão, fases assim, pode realmente hoje ser um norte muito importante para fazer o diagnóstico do leiomiosarcoma.
Isso que o senhor trouxe é muito importante, que é a minoria dos casos. Então, claro, existe um território gigante da ultrassonografia com método de rastreamento e ela vai resolver a grande parte dos casos.
Sim.
Sem dúvida.
O problema do diagnóstico das alterações do leiomiosarcoma é quando você tem vários nódulos, porque existe praticamente um freio no examinador de ele se sentir meio intimidado, quer dizer, em relação a avançar, você descrever nódulo por nódulo, fazer uma boa pesquisa. Eu insisto que você deve procurar identificar todos os nódulos possíveis à ultrassonografia. Numa miomatose, quando você tem múltiplos nódulos, realmente é difícil. E mesmo porque você tem que fazer o exame também por via abdominal, principalmente por via abdominal, os úteros volumosos, mas se você tiver bastante atenção e não se preocupar com o tempo de exame, porque é um exame que vai demorar mais, é possível sim nós fazermos mais diagnóstico do leiomyosarcoma.
Excelente. Então, pode encerrar.
Bom, eu vou finalizar a sessão. Thank you, Professor. Excellent presentation. Thank you. Muito obrigado, Ronan, também pelo debate, foi fundamental. E obrigado pela oportunidade de eu falar um pouco aqui também no campo da ultrassonografia.
Sim, sem dúvida. Muito obrigado a todos e um bom dia.
Ok.